in my master's program to become a gynecologist, menopause was, if not a page, a half a page. Menopause in totality. That's it. Women go through menopause. It is a natural transition. Next page. Prior to the 70s, hormone replacement or menopause therapy was standard operating procedure.
Yeah.
You hit 48, 45, 48, you were put on HRT.
Yeah.
And women thrived. Stop trying to function on standards that were created for male bodies that don't have cycles. We don't consider pain to be normal. As much as it was normalized and women's voices were hushed just because everybody goes through it, why are you special? That was the narrative. We've started to understand that there are medical conditions that will give you pain. So generally speaking, the expectation is discomfort, maybe a little bit of cramping.
Welcome to For Mannerless Women. I'm your host, Adelle Onyango, and this is a space where we're committed to nurturing a new generation of shame-free women. Now, to really be shame-free, one thing we've got to understand is our bodies. And in this episode, we're going to be joined by Dr. Kinuthia, who is a gynecologist, and we're going to be unpacking our menstrual cycles, the conditions that could come with it, how it changes when we go into perimenopause and menopause. This is one episode that's going to leave you knowing your body so much better. All the mannerless or almost mannerless women. This is an incredible way to round off our season 4 because we have wanted Dr. Claire. We have wanted you on here. And what's also funny is a lot of the doctors and medical practitioners we've had in previous seasons are just like, you should get Dr. Claire. And I was just like, yep, we're going to do it. We're going to do it. And we have.
It's happening, finally.
Thank you for making the time to be here.
Well, thank you for having me. I'm so excited. So excited because these conversations will never get old. We need to keep having them.
Yes. And I think first I have to give you your flowers. I feel like there is a new emergence of African female doctors who are talking about things that maybe are to other African women who are not in the medical field. We're hearing things and it's affirming feelings we've had in our bodies or ailments we've gone through.
Yeah.
And it's so liberating to be like, yes, I'm not mad.
I'm not crazy. Yeah.
Exactly.
Yeah.
So I really have to give you your flowers.
Thank
and
you.
I think you're going above and beyond your practice and even just having your show and making sure these conversations are amplified. Well done.
Thank you.
Well done.
Thank you. It's definitely not comfortable, but somebody has to do it.
Yes.
That's how we say it. Yeah.
So I wanted us to dive into our menstrual cycles to begin with, because I think for very many women, myself included, I used to get so confused when I was a teenager and we would hear them talk about how long a cycle is, but then the focus was only when I'm bleeding.
Right.
And so I'd be like, so is it 5 days or is it what are you talking about?
Yeah.
And literally it was just, oh, now you can get pregnant. That's it, you know? There are more phases in our cycles than just when we're bleeding. So maybe we can unpack actually what the menstrual cycle is and then go into the phases.
Right.
Yeah.
So the menstrual cycle in humans, because again, there are different cycles in different mammals, generally who get cycles. But in human beings, it's a hormone-driven cycle of events that is aimed towards procreation. So having babies, getting pregnant and having babies. So if you fail to get pregnant, the cycle repeats itself. So it keeps working steadily towards trying to get you ready for pregnancy. And if pregnancy doesn't happen, then a period will happen. So the best way to describe the cycle is by the fact that we start with at your period. That's the benchmark. That's what everyone can see. This is an actual event. So we look at the menstrual period, the day one, as day one of your menstrual cycle. So what is normal? We consider between 21 to 35 days. It can be anything in between there, and we consider it within normal. Anything less than 21 days, so if you're bleeding more frequently or less often than 35, there's a problem, and you should probably be seeing your doctor. But the main thing about the cycle is if it's healthy, it's such a complex thing though, because there's also levels to it.
Yeah.
But as long as it's within the healthy limits, then everything else functions. So the thing about being in your reproductive ages, that's when your menstrual cycle kicks in. So from puberty to menopause.
Yeah.
In between there is what we call reproductive timeline, and that's when you have an active menstrual cycle.
Yeah.
Before puberty, you didn't have a period.
Yeah.
After menopause, your period actually starts to disappear.
Yeah.
So while you're having your menses, everything else in the female body is tied to where you are in the menstrual cycle. I think TikTok has done a good job, or social media in general, of helping women understand their different phases within the menstrual cycle. The best way to explain it is 2 main phases and 2 events in between. That's how I try to break it down, because if you try and say 4 phases, ovulation is not necessarily a phase, it's an event. The period itself can also just be an event. Some women get a period for a day or 2, so you can't call it an entire phase.
Yeah.
But you'll have what we call the follicular phase, which is before ovulation, and then there's the luteal phase, which is after ovulation. And what your hormones do in between is what leads to those 2 events. So you'll have your period starts on day 1. Your period can vary, but anything less than 7 days is considered within normal. If you're bleeding more than 7 days, again, you actually need medical assistance. So anything where you're bleeding heavily and it's prolonged, that's problematic.
Yeah.
So if your period starts on day 1, by the time you're getting to, depending on, again, number of days of your cycle, for ease of explanation, we use a 28-day cycle, because it's half and half.
Yes.
But technically speaking, the fixed phase is the luteal phase, because once you ovulate, it's a strict 2 weeks to a period if pregnancy doesn't happen. So where your cycle is varying is the follicular phase before ovulation. So if I have a 21-day cycle, I have 7 days to ovulation.
Yeah.
So from day 1 of my period to day 7, I'll ovulate on day 7.
Yes.
If I have a 28-day cycle, it's day 14, and then 14 days, I'll get the next period. If it's 35 days, the same thing, 21, and then you have another 2 weeks to a period.
Yeah.
So that's the easiest way I can explain it.
Yeah.
And then the menstrual cycle is different parts of the body working together to have it function normally.
Okay.
So it starts from the brain, and the brain tells the ovaries what to do. So we have the ovarian part of the menstrual cycle, which is prepare a bunch of eggs, select the best one for ovulation. If pregnancy doesn't happen, shed the lining in the uterus, repeat.
Yes.
That's ovarian part of your cycle.
Yeah.
There's then what happens in the uterus. And basically it's waiting. As the eggs are being prepared, it's told, okay, a pregnancy may happen.
Get ready.
Yeah. So create a nice cushion so the lining starts to thicken. Ovulation happens at the prime of this nice thick lining.
Yeah.
And then we wait to see if conception happens or not. If nothing happens, then I don't need this lining anymore. I must shed it.
Yeah.
So that's purely uterine. So there's what is happening at the ovary level, what's happening, and that's being messaged from the brain. And then that's what's happening in the uterine level, which should help women understand then, even after your uterus is taken out for whatever reason, if you had an issue with your periods, you're done having babies and you're having medical issues, you still have your ovaries, so the menstrual cycle continues. The only thing missing is the event of menstruation.
Because the shedding is not going to happen.
Exactly.
This is, and when you're saying it, I really have tried to reframe especially the period of the shedding. I've tried to reframe it as being, I mean, it is inconvenient, but I've tried to meet my body and like, oh, you're so powerful and you're doing all of these things without me even like consciously knowing.
Exactly.
And when you're talking about the brain signal, I'm like, wow, our bodies are
everything
really...
has to work together.
Yes.
And I've really simplified it because then your thyroid is also relevant. The way your liver is detoxifying your system, the way your kidneys are working, everything has to work together for this menstrual cycle to be normal. So we find, like, for example, with athletes who are extremely underweight and they're working out too much, they stop having a menstrual cycle because then you don't have enough fat to sustain hormone production.
Yeah.
Then we have those who are overweight having very irregular cycles.
Yeah.
Again, too much estrogen being produced in fat cells. So everything within your body works together to give you a clear, normal, healthy cycle.
Yeah.
So a good benchmark for women's health, general health, forget just your reproductive health, is what's going on with your period. And I know there are a lot of women who get upset when you come to the doctors, we ask about your period. It has nothing to do with whether you're pregnant or not. It's good, it'll tell us if you are, but I want to know, are you having healthy cycles? That's a good indicator for me of your general wellness.
And then I know, okay, I can strike out this or this and now look at other things.
Exactly.
And this is so interesting because another thing that I learned is when I move from a cold area, so where I live is primarily just cold.
Yeah.
And then I had a period in my life where I was traveling to like the coast and back, the coast and back. And then my cycle was disrupted.
Yes.
And obviously I rushed to my doctor and I was just like, something
Something
is
is
broken. And we were doing like process of elimination. I remember he just asked, tell me about your work schedule. Have you been traveling?
Yes.
And I was like, yes, I moved here and here. And he was like, okay, I think we've gotten it.
Exactly.
I didn't know that.
So environmental factors, so extreme climate changes, your diet and what you're doing with your diet in terms of, am I eating as healthy as I can? Am I eating too much processed foods and fats and stuff like that? All that will also influence your cycle. Stress. Mismanagement of stress, because we all live in a stressful environment, whether it's work, whether it's professional or social.
Yeah.
But how you're managing stress can also affect your menstrual cycle. Disease processes. So if you're unwell, if you have something that's affecting any other system in your body, one of the big indicators will be that your cycle will also change. So it's not just as simple as, oh, this is an independent reproductive thing.
Yes, that happens alone in a corner,
not
right?
at all. Yeah.
Take me to like the follicular phase. What's happening?
Okay.
Or yes, there are two phases, two events.
Yeah. So if we start with, so we had the menses, the actual period. That's the shedding of the lining because we didn't have a pregnancy in the previous cycle.
Yes.
So as day one starts, at the same time as you're shedding the lining, this is uterine. Remember, we're in the uterus at this level. In the ovary, the hormones being released now, estrogen starts to go up. So we have follicular stimulating hormone from the brain telling the ovaries, we failed to conceive, let's start this journey again. So then the ovaries pick up the message and go, okay, guys, 6 to 10 of us, of you nice little eggs here, show me who's best. So we start a bit of a race until a dominant follicle is identified. If you have a history of twinning in the family, identical twins, you might prepare more than one egg at the same time, but it tends to be it's one at a time. And it's one ovary at a time. So that's the standard average normal. So then as you're shedding, you've already started recruiting eggs.
Wow.
Because then the follicular phase encompasses part of the menstrual phase as well as in the ovary level, preparing the eggs. So once the egg is identified and this is the dominant follicle, we come towards the end of the follicular phase and meet ovulation. So the brain will release luteinizing hormone to stimulate the ovaries to release an egg. Ovulation is actually a traumatic event. If you visualize it, visualize an explosion.
Oh, wow.
It's literally an explosive event. We used to think the egg was microscopic, but it's pretty much like a grain of salt. You can actually see it with the naked eye. But it's expelled out of the ovary into the pelvis. Into the pelvis with the rest of your gut and everyone else and the uterus. There's no compartmentalization. I know people visualize because there's a picture that we all know that the uterus sits like this with the tubes. That's just not true.
That's not it.
That's not true. If I'm the uterus, my tubes sit alongside and the ovaries are on each side. And these structures, the ovaries are fixed, the uterus has some mobility, but it's generally fixed by ligaments at the bottom level. But the tubes are free. And this is where you can conceive even if you have one faulty tube or one is removed from like an ectopic or something. This other one, the release of the egg, the chemicals that are released will attract the tube to come and catch the egg. Otherwise, it would be lost in your belly somewhere. So then it attracts and it goes into the tube. And if sperm is present, we'll meet in the tube and conception will happen. And then travel to go and implant in my nice cushy uterus.
That has been preparing to receive.
Exactly. So they happen concurrently. So the hormones will then tell the ovaries and the uterus what to do at each phase. So then once ovulation happens, and then just thinking about it now, if I contextualize to how you feel. This is the time you have a lot of energy. This is the time, because estrogen is our friend. Estrogen is a happy.
It makes us feel good.
You feel girly, you feel cute, you have lots of energy. This is your most productive. Your concentration spans are amazing. And then we go into the luteal phase. So immediately after ovulation, estrogen vanishes and then progesterone kicks in.
That phase floors me, guys. Like... floors me.
Suddenly you don't even recognize yourself.
Hey, I'm just like, what's going on?
So you can even end up with like confusion in terms of, I had such great energy last week, now I can barely get out of bed.
Exactly.
My appetite is all over the place. I was eating healthy, I'm hitting the gym, suddenly now I just want cake and cookies
crisps
and everything. That's progesterone for you. It's now preparing for if pregnancy happens, I need you to slow down. I need you to give me time to implant properly.
Yeah.
I need you to start putting down reserves, a little bit of fat reserves and a bit of energy, extra energy, because I'm burning a lot of energy preparing for this pregnancy.
Oh, wow.
Yeah.
Okay,
So
when you put it that way.
You have to contextualize it. Then you'll be like, you know what, I can give my body a bit of grace.
Yes.
She's doing a lot. She's doing a lot of hard work.
Yeah.
And then if pregnancy doesn't happen, then progesterone drops. If pregnancy happens, progesterone keeps going up. And it's the one that supports the pregnancy by calming the uterus down, because the uterus doesn't like to be stretched. So even as you place this lining in the uterus and it's getting nice and thick, once implantation happens and I have to grow and carry, because a uterus grows about 500 times its normal size to accommodate a baby. In the process of growing, the uterus's normal response would be contract.
Yeah.
So progesterone tells it, shh, chill.
You got this.
Chill.
Yeah.
Whatever is growing in here,
Yeah.
we need to create a safe space.
Yeah.
So then progesterone going up will support the pregnancy all the way through to term. If you don't get pregnant, progesterone is like, oh, okay, I'm not needed here. It has no shame, it just crashes.
Yeah.
So that's where PMS kicks in. So immediately after ovulation, you might start to feel slower and slower, but then the week before your period, suddenly you're like, because remember I said it's 2 weeks.
Yes.
So that first week might still be, I'm still okay, I can still function, but I'm starting to feel, I'm not okay, I'm not myself. The second week, now you want to cry all the time. Everything is irritating. Everyone. Everyone is irritating.
And then driving, you're just like, what's wrong with
Road rage kicks in. You don't have patience at work.
Yeah.
You don't have patience with any. If you live with someone, God forbid you live with people in the house. Everything everyone does is just you're sensitive. And then for some women, it can be really, really severe. So we'll go into what's abnormal.
Yeah.
But on average, it's just feelings of sadness, of fatigue, cravings that you just can't even explain. Like for me, that's the only time KFC makes sense in my brain. The rest of the time, I'm just like, ugh.
Can I tell you mine is nyam chom, and not from anywhere.
Right. Yeah. The specifics.
From a guy, shout out to Junior, in Kenyatta Market. I live in Limuru.
Oh, wow.
Twice I've gotten into my car.
Yeah, that's luteal phase.
And I was just like, whatever my body is going to me.
Powerful thing. It's supposed to stop you to get exactly what your body needs at that time.
And I can smell it at that, and I'm just like, I will not sleep until Junior, please. So this makes
that's
sense.
What happens. Yeah. And then as we come to the end of luteal phase, as your period is starting again, estrogen starts to come up again, and we repeat the cycle. So you start to get, as much as on your period you'll feel not as energetic, but you're not feeling as horrible as when you were coming towards the end of luteal phase, but you still have no energy, maybe a bit of discomfort, pain for those women who have such symptoms, just overheating, because you also start to feel hot. Because again, remember, this is a physiological process. So your body is going to have those different changes. During your period, you might have those symptoms, but then you start to feel, my energy is starting to come up again. I don't feel psychotic anymore. There's a bit of clarity, and then you're like, oh, because most women will say, I feel really dark, and then the next day I get my period. And then I'm like, oh, that's what that was.
In fact, I'm in the last days of my luteal phase, I'm begging my body, just start,
please.
Like,
I know what you want.
I'm ready. I have everything ready. Let's just do this. Exactly.
Because immediately after that, you go back to back to estrogen happy hormone levels. What
I like is I learned really late about the phases. So for a long time, I didn't understand why I would be feeling slower. And you kind of like go through, if it's 28 days or 35 days, however weeks, let's say it's 4 weeks, you want to arrive in each week the same way you were last week. So if you wake up in the morning and you go to the gym and you do a particular workout, or if you, like for me, I love going on my walk, I love doing these things. If you were meal prepping and so on point with all of these things, and then the next week, even getting out of bed.
I walked how far yesterday? You're like, no,
I don't want to do
never
it.
Mind.
Yes, so I started tracking. How do you use an app to track? And just to understand where am I, so that if I'm unable to wake up for this thing, I don't shit on myself and say, look at you failing, and last week you were doing this. I'm like, oh, okay, that's where we're at. So let me slow down.
So I have that conversation pretty much every day with my patients, because you need to learn how to optimize for what your normal is. Stop trying to function on standards that were created for male bodies that don't have cycles.
This is
get
true.
through. So in your gym, if your trainer is male, he's expecting you to show up the same way, like you said, every single week, but that's not possible.
Yeah.
And so even at work, if you're really, really productive one week and then the next week you can't get through it, I'm always talking to my patients and saying, track your cycle and schedule accordingly.
Yeah.
You schedule so that you're not failing.
Yeah.
Because then the week that comes that I can't get out of bed, I've met all my deadlines.
Yes.
I'm good. I can actually relax during this week, give myself grace. This is the time to go for my massage and have a little bit slower pace.
Yeah.
And that should be okay.
Yeah.
But you sort of have to understand what your normal is first for you to be able to accommodate for those changes. Yeah.
And I like how you've explained it, because like one could think a luteal phase is you being lazy, is you, but your body is doing like heavy.
Yeah. Oh, you were lifting in the gym last week. Me, I'm lifting internally this week. It's a lot of hard work, and it will explain, especially if you're the type to monitor your temperature as well. It will explain those changes with your temperature. It will explain the changes with your energy levels.
Yeah.
The energy is being concentrated, because remember, if you were to get pregnant, all energy resources are sent there.
Yeah.
This has now, you are now a vessel.
Yeah.
That's how biology looks at us.
Yeah.
So as much as we may be as empowered and as we are as learned, you're still primarily an animal.
Exactly.
And that's what the focus will be. So that's where the energy has gone. It's not that you're lazy or you don't understand or you don't have goals, you know.
Yeah.
And especially so if you have abnormalities, if you have a medical condition that's affecting this normal cycle, it may amplify these symptoms even more. And so you have to understand it's not me refusing to, and I think it's not necessarily just the individual person going through it, it's us generally, because then your environment will also feed into that idea that you're lazy and you're not achieving, because it starts in high school. Nobody prepared you properly for your menstrual cycle. Then it comes, it's heavy, it's painful, you can't function.
Yes.
Your energy levels dip up and down. You used to be a star athlete, now suddenly we are seeing some faults. Instead of being supportive, because we don't have that information, they drum it down. And so by the time I'm meeting someone in her 20s or 30s, the messaging in the brain already, the mindset is already messed up. So we have a lot of work to unpack and learn, and then start to understand the body as it is.
And meet it where it's at, you know. What about pain? Because this was also something else that was normalized, right? And again, even if a lot of women, when they were girls in high school, if you said you were having cramps, it's like, I suck it up and go to class.
Go through this.
Exactly.
You think you're more woman than the rest of us. And we all went through some abuse. I think it
was. And to be honest, like, I'm very fortunate. I've not had severe cramps or like cramps really. In fact, when they do come, that's when I'm like, hey, what's wrong? Something's up. But the few times I have had cramps, I'm just like, please, everyone stop what you're doing. There is an emergency.
Stop talking to me. Don't ask me to do anything.
Extreme. How come we normalize pain, and should we normalize pain within a menstrual cycle? So
no, pain, we don't consider pain to be normal. As much as it was normalized and women's voices were hushed just because everybody goes through it, why are you special? That was the narrative. We've started to understand that there are medical conditions that will give you pain. So generally speaking, the expectation is discomfort, maybe a little bit of cramping, which is not something that is debilitating. That's the difference here. So there are women who will experience cramps because the uterus is contracting to shed the lining, and there is receptors in your body that will tell you there's a painful event happening. But usually with a hot water bottle, maybe a warm shower or a warm bath, comfort, sitting in a comfortable space, taking over-the-counter pain meds should resolve it. That is considered normal. Now, pain where you can't get out of bed, where you can't function, where you're throwing up, where you're passing out, that's not normal. And that's what we need to differentiate between the two, because there are women who it's very rare but are completely painless. Like you described, the average will be that I have cramps that I'm aware of, and sometimes they'll change depending on your activity level. If you are more fit, if you're eating a bit healthier, you'll have less cramping. If you have gained a little bit of weight, again, disrupting the normal hormones, you may have an awareness of a bit more pain. But it's not anything, like I said, that is life-changing. You can function. You can still function. You're uncomfortable, but you can still function. Anything beyond that, where I'm in so much pain that I end up in hospital being put on IVs, that's not normal, and we should be investigating. And that's where different kinds of gynecological issues would cause that kind of pain.
Which we're going to get into. Another thing, so after, all I had was PMS. And I really wish I could go back in time and correct how we used to throw PMS around.
Yeah.
Like, I don't know. It surely must have been ignorance. Like, she's PMSing. I'm PMSing. We didn't really...
We just tagged it because that is what it is. The change of the system, the luteal phase symptoms is what we call premenstrual syndrome. And it's just that we made it a bit more casual. You didn't understand the gravity of what you're talking about. But truly we were labeling it correctly. That the way you're feeling, you're irritable, you're just angry at everyone, you're not in the mood to do anything, you don't have energy levels. That is the definition of PMS. Yeah.
But later on, I want to say in my 30s is when I first came across PMDD. And I was just like, Yani, don't we have enough on It's just like, is it not enough, guys? Just when we think we're doing good, we get hit with the luteal phase. Like, what is this?
Something that's supposed to be normal. This is a normal part of my body, so what do I do?
So could you what is PMDD?
So we have, from what we've described as PMS, that's what we consider within normal. Now PMDD, so PMS, premenstrual syndrome. PMDD is premenstrual dysphoric disorder. And that is psychiatric. So this is where it's not just, like I said, there's a bit of sadness, there's tiredness, there's feeling of almost like laziness. I just don't have energy, lethargy, I'm fatigued, I don't have the energy to do anything. I'm irritable, like everybody's pissing me off. That's PMS. Now, if you're getting to the point where you're sad to the point you're crying, it's persistent. It's almost like I could actually get diagnosed with clinical depression. For some women, it's anxiety. So it's no longer just symptoms of or similar to. This is depression. This is anxiety. If you're getting to the point where you just can't function, we are crying, we are irritable to the point where you're having suicidal thoughts, you're actually thinking about harming others or harming yourself. It gets to the point where now, is this just... what's going on? And again, it's a hormone imbalance issue where at the brain level, we are messing around with the same kind of chemicals that you would have that are disrupted with someone who has clinical depression or anxiety. Or for some, it comes off almost like a bipolar disorder because in the early part of your cycle, you're almost manic. In the second part, you're almost depressive. So PMDD is extreme. And it should be treated as an emergency. So it's usually care between your gynecologist and your psychiatrist. So it's not something we can take casually. And we do see such extremes as well now in menopause because as the hormones are starting to shut down, brain chemistry can be affected to that level. So there are those women who will have just the same mild symptoms and then someone else is actually suicidal, actually homicidal. Like they're problematic. Same thing we see with postpartum blues and depression versus postpartum psychosis. So there's a direct link with like I said, everything in the female body works together to maintain healthy. So if whatever phase is going on that's disrupting your normal hormonal levels will have a direct effect with how your brain function is. And so if we're at PMDD, this is something that needs to be taken seriously. And that's, again, somebody who needs to see their providers. And usually it's a multidisciplinary approach. So we're not just working as one specialist. So gynecologist tends to be who we see first because, again, you're linking it to your cycle. Some women go psychiatrist first because if you already you're more predisposed if you already have clinical depression or you've already have a different personality disorder diagnosis or a major psychiatric diagnosis makes you higher risk for PMDD as a woman. So then they'll have a psychiatrist on board and then the psychiatrist will bring a gynecologist on board and then psychologists as well because talk therapy, behavioral therapy, all that now comes into play. So it's actually more severe in terms of what you actually need to follow up on. PMS we can manage socially. You can find ways to cope and manage your symptoms. But if you're getting to PMDD, you need to understand it's not okay to try and manage it on your own.
And I think also the heavy factor for me is that this is happening with every cycle, right?
That's the worst
this is
part.
not a one-time event that we're dealing with. As soon as you start to feel like yourself again.
You feel horrible for 2 weeks out of a month.
Exactly.
For 2 weeks out of 3 weeks if your cycle is short. Remember, there's people whose cycles are very short. So it's literally the whole month. Because twice a month, you feel like you're crazy.
I don't know, like, I know we still have more to unpack, but so far I'm just like, we need better care, especially socially. I wish, I mean, this is a start and this is great, but everywhere that hosts women, so your workplaces, your schools, etc., government services need to understand like the support women will need through cycles.
Yeah,
right?
and that this is okay and normal. Not you're not doing me a favor. It's not an exception. It's not extra. This should just be standard. Yeah.
Yes.
Yeah.
Let's pivot to PCOS. And I'm very excited because I want to learn more. I think I've gotten very confused about what it is and how it presents itself.
Right.
Yeah.
What do you know? Let me talk to you. Talk to my patient.
What I know is I hear a link between PCOS and fibroids.
Okay.
PCOS and maybe more hair growth in places that maybe you would not, many women would not experience it. I hear PCOS come up with problematic, uncomfortable symptoms. So it's also something that needs to be managed by, with a medical doctor working with you. What else? I've heard PCOS. What I've heard more of is symptoms.
Yes. Yeah. Yeah.
But I'm like,
what is PCOS?
Why?
Yeah.
Okay. Why?
So PCOS, polycystic ovarian syndrome. It's not the same as just having polycystic ovaries, which is one of the criteria. So you have to, in medicine, we're a bit thorough in terms of how to make a diagnosis. It's not just I saw polycystic ovaries on your scan, then you have PCOS. I also have to tie it in with hormonal dysfunction as well as the symptoms you present with. So it tends to be the criteria fit into those three categories. But PCOS is now more than ever we understand it's not just a hormonal disruptive disorder, it is actually a body disruptive disorder. And just because, like I said, there's no way to delink the menstrual cycle from the rest of your body. And so areas of PCOS that have like insulin resistance is a big factor. How would you explain that if you're just looking at reproductive hormones, right? So in PCOS, typical symptoms, let's talk about symptoms. Yeah. Typical symptoms will be she's struggling with her weight, so getting bigger and bigger and not able to lose the weight despite having a healthy lifestyle, trying to eat as healthy as possible, working out aggressively. Then we have acne of various severities, but some it's very, very severe acne. Then we have, like you said, we call it male pattern hair distribution. Okay. So you're balding on the head, but now you suddenly have facial hair, you have chest hair, you have lower belly hair that women would typically not present with. Okay. That's what we call hirsutism in medicine. So that's the third typical symptom. For some women, it's just a disruption with their period. So irregular periods is another symptom where you have a bleed more than 35 days. So they'll tell you, I've had a period 3 times this year, or I've had a period like the last one I had was 5 months ago. That is more in time with PCOS. So it tends to disrupt the regularity of your menstrual cycle. Then those are the primary symptoms that we'll tend to find. Now, there's also symptoms relating to insulin resistance. So the first one I've mentioned is weight, but there's also now symptoms around you're more predisposed to what we call metabolic syndrome, so hypertension and diabetes. So you'll find this person also becoming pre-hypertensive or pre-diabetic. They have crazy cholesterol levels. So they'll usually be seen, if you're seen by a GP and they tell you you're very unhealthy, you need to change your lifestyle, you need to change your diet. But despite everything you're doing, your period is getting more irregular, all these other symptoms are kicking in. So again, multidisciplinary approach. Yes. You have to figure out who is the first one I need to see. Yeah. And are they equipped to bring in the rest of the specialists that I should have on board? Because it's also another condition we shouldn't be treating just as gynecologist or just as a physician. Yeah. It's something that needs teamwork. So PCOS, sort of now, once you look at those symptoms, and it's not all of them with every woman. That's what makes this complex. It's not that you'll come and tell me textbook.
Then now it's like, I know what that is.
Spot on PCOS. Yeah. You need to. No, that's not. Unfortunately, that's not how it works. Some will just come, I don't have a period, full stop. The last time I had a period was 6 months ago. The previous time before that was 3 months before that. That's the only symptom. I'm skinny. I don't have any facial hair. I don't have hair any in strange places. I have a bit of acne, nothing too crazy. So then, is it that it's PCOS or not? So that's why we talk about criteria. So you have symptoms, but I also have to do a scan, a pelvic scan, and see polycystic ovaries. And then in addition to that, do your hormone levels And there's specific readings that we have. Like I've talked about the LH, luteinizing hormone, follicular stimulating hormone. There's ways that they're supposed to interrelate to give us a normal cycle. There's what your testosterone levels are doing, because again, you're presenting certain type of features. So progesterone may be higher than what I expect. So there are readings I'll have to tie in with your hormone levels. So a lot of women will come to me like as a second or third opinion and be like, I was told I have PCOS 10 years ago, 5 years ago, and that's what we've been managing for, but all I've ever been put on is the pill. Then I'm like, okay, what was your diagnosis? How was it made? Oh, we did a scan and we saw cysts on the ovaries. I'm like,
And then
what else was done? No, that's it. I'm like, okay, so then you don't have a PCOS diagnosis.
Yeah.
So we need to investigate again, and we actually have to fit the criteria to make sure that you have a proper diagnosis so that we can decide the management protocol.
Yeah.
Unfortunately, like I said, you don't have all the symptoms, you don't have the same issues, so it will also be goal-driven in terms of management. Are we trying to get regular cycles? Are we trying to conceive? The medication or the management for those are polar opposites.
Really?
So you need to come in knowing my goal is I need to have a period regularly or protect the lining of the uterus. If I'm not shedding it regularly, let me just make sure I'm not retaining those cells for extended periods of time. Versus someone who's coming in, my primary issue, of course, with irregular periods comes subfertility.
Yeah.
So my issue is I'm trying to conceive. That's usually the primary concern. I'm not getting a period. Does that mean I can't conceive? So if your issue is fertility, then our focus for management will be fertility driven. And that's where it gets complicated, because again, you're not going to have 2-3 women with PCOS in the same room on the same management.
This is interesting because a lot of women I've spoken to immediately got told, we need to put you on the pill.
Yeah, yeah.
So it's almost treated as like a one-size-fits-all approach.
Yes, because the irregular period, that's the primary concern. So just to explain a bit more, with your menstrual cycle, it's protective in that you're shedding this lining every month or every part of your cycle with your period, because those are cells that are no longer needed. So the pregnancy didn't happen, we don't need this cushion anymore, out go the cells.
Yeah.
These cells are very, very fast proliferating in medicine, so very fast growing and changing. They have a very high risk for abnormality. So I want them out of your body every cycle.
You need to shed,
yes, get out.
Yeah.
So if you're not shedding them regularly, for us medics, it's a concern. Because later in life, one of the long-term issues with PCOS untreated tends to be, because there are women who say, I don't care, I don't have a period.
Yeah.
It's not that simple. If you're not shedding that lining, then it's going to be problematic later. So one of the long-term issues we see with them is what we call endometrial hyperplasia, which is a very next risk for endometrial cancer. So that's cancer of the lining of the uterus. So these cells are not safe in your body. They need to be shed. So either I get you to shed them regularly, which is what the pill does.
Okay.
I'm giving you hormones externally that you take for 3 weeks, and then you withdraw for a week and get a bleed. So I safely get rid of this lining, or I stop you from forming them all together. And that's where progesterone only contraceptive options, unfortunately, like I said, research in medicine, we are very behind.
Yeah.
So most of the tools we have, we manipulate using the medications we have, which tend to be contraceptives. So then everyone gets this misunderstanding that all they did was put me on the pill. I didn't ask for contraception. But I'm using it for the hormones because I'm using it to manipulate the cycle to protect the lining of the uterus. So either I want you to shed it monthly, so that's why we're putting you on the pill, versus somebody who says, I don't care for a period, then I give you progesterone-only contraception to stop you forming the lining. So that we just, unopposed progesterone, we're not caring about estrogen levels. This lining is never being told form fresh.
Yes.
So then if you're not shedding it, you probably miss your period. There's some contraceptives you're on and you're told, if you don't see your period, it's fine.
Yeah.
So then I'm protecting the lining long term.
Got it.
So that's why those options are usually given as the mistake is saying that that's the treatment.
Yeah.
And not explaining it in detail. But again, how do you explain PCOS to someone without a medical?
Yeah. I get it now
problem,
because like I don't want any long-term issues if we
Yes.
keep this lining here.
Yeah.
So it needs to go out.
So either we are not
Or
forming
not
it at
form
all,
it, yeah.
or we shed it regularly. But if you came in and your primary concern is fertility, these are all contraceptives. So now I forget about what your cycle is doing and I focus on getting you pregnant.
Yeah.
So we need to stimulate the ovaries to give us eggs. So then the treatment for PCOS with someone who's trying to conceive will be ovulation induction or assisted reproductive techniques to get us the eggs that we need for conception. So that's why the two treatment options are very, very separate. Yeah.
This is so interesting. I'm just like, okay, I've gotten it.
Yeah.
I've gotten it.
Yeah.
Earlier, this year on one of our other shows on the LCA network, we had a lady come on and share a story about being diagnosed with endometriosis after 9 years of first being dismissed, and literally she was told that, very common statement of like, you're not the first woman to get a period.
So why is yours so special?
Why is yours so special? And she used to get, you can imagine boarding school asked like, what do you mean you have crumbs, you can't get out of bed?
Yeah.
She would stain, right? And she said she would just get whenever her periods came, she would just almost be panicking because she knew it doesn't matter how heavy the pad is or what, in no time it would be full, she would be staining. And again, in a high school setting, there's always those kids who are going to make fun of
hygiene, why are you keeping your pad for so long?
Exactly.
Blah, blah, blah.
And so for a while she thought she was just handling this periods thing wrong. Something was wrong with her. Then came work and she would get fired because she couldn't get out of bed when she's on her period. And then they're just like, well, it seems like you don't want this job. You're not being serious. Went from doctor to doctor to doctor. One male doctor told her, I think this is psychological. You need to see a counselor because the pain, all women go through pain. And it's only, and she said, and I'm going to credit them, she went to Nazareth Hospital and she saw a female gyna who said, I think this could be endometriosis. And what she said is like, finally I had a word. That after 9 years,
I'm not crazy.
I had a word, right? So maybe we can unpack what endometriosis is.
Right. So you've said correctly, and it's one of those medical conditions that's diagnosed. From the average woman will say an average of 5 to 7 years to achieving a diagnosis, mainly because I'd say even as recently as 5 years ago, we didn't have a name for it. Like it wasn't recognized as a medical condition. It's only now that we are starting to understand, research is showing that yes, there's actually physical evidence of an issue, and now we need to give it a term. I don't even remember in my residency training, so that's postgraduate, when you're becoming a gynecologist, I don't remember it being more than just a footnote that a condition known as endometriosis exists. So then that's part of the reason why. And that's gynecology. So I'm not talking about undergrad.
So you're already specializing, right?
Yes. And I'm the specialist who's supposed to look after someone with endo. So then you can imagine the physicians, the surgeons, nobody else has
because if it was a footnote for you, for me, then now...
Undergrad, nobody said anything about endometriosis. It's just like menopause. It's wild, but we'll come to that. So endo was now, we've started to understand it a bit more now, and endometriosis and adenomyosis are similar, so I call them cousins. So just to explain what they are, it's where cells that are very similar in the behavior as what we find in the lining of the uterus are found outside of where they're supposed to be. So they're not necessarily the actual cells, but cells that are similar. And in medicine, when you don't understand the root cause, it's difficult to then understand how to treat. And that's what endo was for the longest time. So as more and more research is being done, we're starting to understand several theories have come up as to why does endo happen in some women and not in others. But over and above all the speculation that we used to have and the theories, the one that seems to be standing true is it's an autoimmune issue. There's an issue to do with inflammation and how we regulate it in the body and how your white cells recognize self and non-self. So it's a bigger picture than just abnormal cells from the line, from the uterus being spread everywhere else. So cells that are similar to what is in the lining, so endometrial cells, if you find them implanted just in the muscle of the uterus, that's what we call adenomyosis. And it can just be that simple. And those women will have very, very painful periods and very heavy flow. So similar to what you're describing with the lady you've described. And then if those cells are implanted outside of the uterus, entirely outside, so ovaries within the rest of the pelvis, like I said, there's no gates separating all these organs. Your bladder sits right in front of the uterus, right in front of the rectum. All of it surrounded by gut. So if these implants are found on any of these structures, or if they come up to where your liver, your stomach, spleen are, and then if they go further into the chest, you can find endo lesions on skin. You can find it in gums and teeth. We've seen some women with lesions in the eyes, in the brain. We know of women who've had them in the lungs, like Jambi Koikai. So wherever these cells implant, they behave the exact same way as if they were in the uterus. So the signal to shed, they bleed. That's what happens with endo and adeno. Now, the rest of your body is not built to deal with blood. So blood is a foreign object in the brain. You will have seizures. You will have a collection of a clot, and you can actually end up with a stroke because you're bleeding around the brain. If it's in the lungs, the lung collapses because it's supposed to be holding air. If it's on skin, then you'll have a disruption and you'll actually see bleeding from the skin. If it's in the eyes, you can imagine you're bleeding into the eyes, intraocular pressure rises, you'll go blind. So anywhere that you're not supposed to have an extra amount of fluid, if you're bleeding in that area, you're going to have very severe symptoms associated. So if it's in the gut, you'll have women who have endo and tell you, I have problems with digestion, I'm bloating unnecessarily, I get constipated during the time of my period, or I'm having blood in my urine or stool, depending on where the lesions are. You can also have lesions in the vagina, so then painful sex becomes a big issue. You can't even use a tampon during the time of your period. It's so painful because now you can't tell is the bleeding coming from the uterus or from the lesion on the vagina. It's the same route. But when you try and place something in there, if you're using a tampon, it's too painful for you to be able to do it. It can be rectal, so that every time you're getting your period, you're also bleeding in stool. So because of implants within the gut. So endo is a debilitating whole body illness as opposed to adeno, which is limited to just the uterus, which then means that for as long as your ovaries are present and you're getting a message to shed this lining, it's problematic across the different parts of the body that are affected. And that's the big difference between endometriosis and fibroids. So if you're going to talk about them as the same, so fibroids also give you painful periods and very heavy flow, but these are benign. They almost look like potatoes. That's the best way I can describe them. They're potatoes growing within the muscle of the uterus. And as they get bigger, they occupy space, so you get pressure symptoms. So you're peeing all the time. You're having constipation during different parts of your cycle. You're having a lot of pain and a lot of pressure. Sometimes you feel like, the women describe, they feel like something's coming out. So the uterus starts to prolapse downwards. Then you can have, because they increase the surface area of the lining of the uterus, you have heavier bleeding and for longer periods of time. So your period gradually gets heavier and more prolonged. So if it was 5 days, it gets to 6 days. Next thing you know, you're bleeding for 2 weeks, like that. So that's more fibroids related. But with fibroids, we can take out the fibroids or we can take out the uterus and you're fine. You're cured. We're done with that. Endo is not that simple. Because I'd have to send you into menopause by taking out the ovaries or suppressing them for us to control the disease. So that's the main difference between those two.
Damn, I didn't know that now those cells could be found
anywhere in the body.
Your brain, your eyes, your gums, your skin. And so this, if they're in these places, this would be happening every month.
Exactly. And that's the problem with reproductive health conditions or diseases. It's monthly. It's with your cycle. So it's every single... So an example is if you have thoracic endometriosis, which is in the lungs and the chest, every time you get your period, your lung collapses. You're in ICU every month.
But when I come and see you, we almost have like a timer. Of like, we need to figure this out.
And we will reinflate your lung. But again, by the time you're recovering, your next period is due.
Oh my God. And the signal has been sent. Guys, shed.
So bleeding starts again. So the treatment usually is surgical, that we actually have to go in and take out as many of the lesions wherever they are so that we stop this process of bleeding and reduce the inflammation that bleeding is causing. Because the harm or the damage is coming from the inflammation. Because your body reads blood as foreign in that part of the body and attacks it and harms the cells around it as well. So in the process, you damage the organ repeatedly. You end up with people needing transplants because you've caused so much damage to whatever organ system that is. So that's what endo is. And again, given how I'm describing it, you can see it's not just a reproductive health issue. It's a whole body issue. And it's not easily explained as, is it a hormonal thing? Why are these cells surviving in places they shouldn't be? Something is off with the immune system. And inflammation is a big factor here. And not inflammation the way we understand it as laymen. Inflammation is the way your body fights disease. It's only problematic when it gets out of control and starts killing normal cells as well. So that's the kind of inflammation we're describing. So in such a scenario, the management protocols first of all, diagnosing it, I'm blind. I can't see. You can barely see, you won't see these lesions unless they are superficial on skin, for example. Otherwise, internally, your symptoms sound like IBS if it's gut. It sounds like you have epilepsy if you're having seizures every month, you know? So it's only when it's tied to, it's happening only with my period, which takes a bit of time.
Which why you say the 5 to 7 years.
Yes. So now, when you come in with a symptom of I have very bad pain, typically endo pain starts before the period. So in your luteal phase, compared to fibroids, it will start with the actual period. Typically, it will start a week or so to your period, or from the point of ovulation onwards to the time of your period. So in such a scenario, then you have to go to someone who understands what endometriosis is and can screen for it. And now we are getting better with imaging, so we don't have to do surgery as the diagnostic criteria. We have certain ways we can do the ultrasound on your period or do an MRI and just try and see, are we seeing changes typical to what we'd expect with endo? Because sometimes, and again, there's grades to the disease. So you can have very mild all the way to very severe. So we'll grade it up to grade 4. Depending on where you're staged, then we decide on what the management protocols are. There are women with endo that's just limited to the pelvis, and so we'll manage for pain during the time of the period, heavy flow, things like that. But if it's widespread, if it's in, you know, life-threatening areas, then we have to deal with it a bit more aggressively.
And man, this is just like...
And it's just being a woman.
We have to be more empathetic, guys.
We do. We really do.
Because this journey is hectic.
Yeah.
And is it true that if you're a Black woman, you're higher risk for endo?
Yes, for endo, for fibroids, for a lot of the medical conditions to do with gynecology. For some reason, it's actually ironic. We have the worst pelvis for pregnancy. Black women. Yeah, despite having the most generous hips.
Yes, what is happening, guys?
So hips and superficial subcutaneous tissue, fabulously endowed. We don't have the gynecoid pelvis. The pelvis itself, the bone structure that allows for a baby to pass through during labor, is the most ideal in Caucasians and in Asians.
Oh my
and then Hispanics and then Blacks. So we tend to fall behind even on that. Now, when it comes to medical conditions, the inverse is true. Black women are more high risk for fibroids, more high risk. And that's why you'll hear a lot of women will say, yeah, even my mom had them, my auntie, my cousin. So it's more common genetic. There's a bit of a genetic predisposition around race as well. The same with endometriosis, the same with PCOS as well.
Oh my goodness. Okay, but you've broken it down so well. I think I have a deeper understanding now.
Yeah.
I want us to switch gears to perimenopause. And I spent day before yesterday, actually, I was with my aunt who's 66, and I said something like, "Oh, it's this perimenopause." Like all of a sudden, I started sweating, and I never said in my life. And so I was telling her, I even told my doctor, "Amma, is it perimenopause?"
Yeah,
because I had learned in the previous season from Dr. Kenya how she was like, with symptoms for perimenopause, it's everything from your hair to your toes.
Yep.
Right? And it's, I think one of the strangest she said was like, you can even get itchy ears. And I was just like, what? Why?
Why? Explain to me.
Like, just why?
Yeah.
And my aunt said, what is perimenopause? And I said, there's a whole chunk of time where you were experiencing symptoms when you were younger.
Yeah.
And you guys just didn't have
the language, the knowledge. Yeah.
And you just thought, maybe something's wrong with you, or you just had to persevere through it. But I was like, there is a thing called perimenopause. And now at least we're like understanding, this might be this or whatever. But what happens to like my menstrual cycle when I go into perimenopause?
So you're coming to the tail end of reproduction. So basically what happens is we are conceived with the eggs we're going to have for our lifetime. So it's not just that you are born with them, they are with you from the point of conception. So you tend to carry your grandma's eggs. Like the lineage is
Isn't
from
that just
far
so
back.
powerful?
It really is. It really, really is. So we are conceived with the finite number of eggs we're going to have. Yeah. And then for some reason, the human system, the reproductive system is very wasteful. So by the time you're born, you have several million eggs. By the time you get to puberty, you have 400,000.
Surely.
Where did the others go? Where are the rest? Like, what's going on? Yeah. And then with every cycle, you recruit 6 to 10 to ovulate one.
Oh, yeah, because you're calling the best to step forward, right?
And they're not stored.
Yeah.
These ones who fail to meet criteria get destroyed.
Surely.
They're gone. They're gone. So that's why we end up at menopause, because we're using up so many eggs, and not necessarily for reproduction, just for a normal menstrual cycle, that by the time you're coming to a certain age, there'll be no more eggs left in the reserve. So once your egg numbers drop, it'll then mean that there are cycles you'll come to that there's no egg to release, right? And if there's no egg, like I said, ovulation, 2 weeks later, a period. If you don't ovulate, then no period. So that's the easiest way to understand perimenopause and menopause. So perimenopause, we consider it when you start to have irregular periods. Your periods are becoming less and less frequent, or they're becoming lighter and lighter to the point where now you start skipping a month or two. Suddenly you're having every 3 months, or another 4 months go by and then the period shows up. Menopause is when you've had a full 12 months without a period. Now you're in menopause. But the transition is what we're calling perimenopause. On average, it's 4 to 10 years. We've actually started to understand that a bit better. So there are women who will be in perimenopause from their mid to late 40s. It's becoming more frequent that we're seeing women in early 40s as well. And they start to notice that their cycle is just diminishing, and then it comes with all the other signs and symptoms of perimenopause. But what happens with the menstrual cycle is there'll be a failure to launch for some cycles. There'll be that my brain has told my ovaries, hiya, there was no pregnancy, let's recruit. The ovaries like,
recruit who?
Sector D. What was Sector D?
Silence.
Nothing. Even one, nothing. But that was the sector selected for this cycle. So then we don't have anything for ovulation. If you don't ovulate, there's no period, because then your body wasn't told to prepare for a pregnancy. So then we miss that period. So then the next cycle, we may find, okay, sector E
has brought one.
Okay, haya, at least tuko na kamoja. Then you get a period after that ovulatory cycle. So you will be having an ovulatory cycles more frequently in perimenopause, and then finally you get to a point where there's just nothing left. So every month your ovaries are just saying, "Ay, guys,
no comments.
Anyone? Anything? Anyone at all?" And when you get to 12 months of absolutely nothing, then now we call that menopause.
And so does that mean after menopause, the menstrual cycle
is done?
Is no more?
Yeah, completely.
So none of the symptoms, none of the...
Everything shuts down. It's a very quiet, calm time.
Yeah, I'm just like, how soon? How soon?
You just have to transition through perimenopause safely and sanely to get to menopause. But after menopause, sort of, it's a very crude way to describe it, but we literally turn into men. Because the bad thing about perimenopause is, again, the eggs were where we were getting a lot of our estrogen. So now I no longer have estrogen. Now, estrogen is such a vital hormone, and it's because of perimenopause that we're understanding it affects everything from head to toe. It's estrogen that's the issue. So as your estrogen levels start to drop with perimenopause, hair loss becomes a factor. Your skin starts to do whatever it wants. You can't even describe what's going on. Is this acne? Is it dryness? Is it, like you said, the itchy ears? It's a lot of dryness and buildup of wax that you didn't have as an issue before. Dryness of the eyes, same thing. It tends to be dryness of mucous membranes. So there'll be oral dryness, vaginal dryness, the eyes, the ears. So then that's the irritation causes, the dryness causes irritation and itchiness. With vaginal dryness, then you'll have pain if you're having sex. You have micro tears. You have very bad discomfort, increased infections. So UTIs become more common, yeast infections become more common. And that's, again, because of estrogen dropping. It's what gives us collagen. So then wrinkling and skin sagging, that's what happens. So the aging process is a little bit faster because we no longer have estrogen. Then the biggest things it has a biggest influence on is bone health. So you start to lose your bone mineral density and ability to incorporate calcium. And so that's a big issue we find, because then women, we have a lot of morbidity and mortality because of falls when you're older, and you have a risk, literally just slip a little bit and you've broken a whole bone. And hip replacement, you hear women who have had to have a hip replaced, and then from there it was just downhill. They lost quality of life, they were unable to recover. Then it also has a big effect on cardiovascular health. And so now you're higher risk for heart attacks, for strokes, for deep venous thrombosis, which is clotting in abnormal places. All of this is estrogen depletion at its best way to describe it. So then the symptoms that you're having around perimenopause are because we're not producing estrogen the way we need it. And that's where hormone replacement becomes an option for those who, again, if you qualify, because it's also linked to what your health looks like in general. But it's one of the things that if there's an unfairness or a crime against women, historically, medically. It's the study that came out that demonized HRT.
Yeah.
In the 70s. Prior to the 70s, hormone replacement or menopause therapy was standard operating procedure.
Yeah.
You hit 48, 45, 48, you are put on HRT.
Yeah.
And women thrived and eased into... So there are some women who just don't know what perimenopause is because their doctor had them on hormones automatically. Then this study came out and said, HRT gives you breast cancer, ovarian cancer, endometrial cancer, shut down completely. It was withdrawn fully, even from the women who already were on HRT. So it sent a lot of women into actual psychosis. Yeah. Because suddenly, before, at least you are giving me a small dose of estrogen, suddenly you've withdrawn it completely. Then for the rest of us, it was not even an option. Yeah. You come and talk to, and I mean it. When I say with my heart, my training in my master's program to become a gynecologist, menopause was, if not a page, a half a page. Menopause in totality. That's it. Women go through menopause. It is a natural transition. Next page.
They will be fine.
The ovarian system. End of. And that's the gynecologist. So what did they train the rest of us in medicine?
So, I mean, what I'm also hearing is like when we talk about misogyny in medicine, it's in the research and in the training.
Yes, because the research governs or dictates how the training will be set up. Because we tend to be trained on evidence. So medicine, that's why I can't answer when people ask me, can I take this herbal preparation for this medical condition? If there's no evidence, I have no business. You're asking a scientist. There must be research for me to base my answer on. Yeah. And so with menopause and not having research, or with any of the female conditions and just not having research on women's bodies to give answers about the condition that's happening within you, then now it's guesswork. Yeah. And there's no medical training program that's going to teach guesswork.
So they'll just add a footnote. There's this thing we've heard.
More research needs to be done. It used to be the end of most things that didn't have a proper explanation. Because it's also not fair to send me out and say, oh yeah, the theory around this is this. But it's a theory. I can't base clinical care on that. But then if there's no funding for research, then it directly affects the quality of medical training, because you're not going to be trained on guesswork. It's never going to be about guesswork. It has to be rooted in evidence. So even now with practitioners, basically what I'm saying, anyone who was trained historically, if you're not reading, if you're not keeping up with what's being published, if you're not looking into research, you're not reading your journals, you'll see a big difference, because you'll still go to a doctor who has no clue what you're talking about, or minimizes symptoms because they don't have an understanding, or some who will divert care to something that they know they have skills for but have not gained. There's better options out here, but because I don't have the understanding or the skill base, I'll direct you towards what I know. So that's the explanation based off of that. So when we're talking to different specialists, or if you're going in to see your physician, there's questions you have to also ask around it to advocate for yourself, so that you understand, are you the best possible provider for this particular condition? Do you have extra training? Is it something you're passionate about, you've been reading on? What's the criteria I can use to decide that you are the best person for me to see for this condition? Because you could be just a general physician, for example, and I come to you to see you about cardiology issues. Surely there's somebody else who's trained for that, right?
Someone who's done a deeper dive.
So the same will apply even in gynecology. If you're just based off of me from med school or from training, you're going to get the worst quality possible, because even I don't know. But then if I've gone ahead to do a bit of a course or a bit of studying, a bit of extra reading, because medicine is, you read every day. Like, it's the most exhausting type of profession, because there's something new to learn every single day.
You're understanding things afresh, or there's more knowledge being gotten on.
And you also have to unlearn, because what you were taught, as we were taught, pain is normal, dismiss. In fact, and you're the gynecologist. In fact, the thing that still traumatizes me about how I was trained is the medical procedures we did without pain meds for women when we were training still haunts me. We had no business.
I saw this video of this lady talking about how she went to see this doctor. She wanted to have an IUD put in, and the receptionist said, "Oh no, the doctor doesn't use any sort of like numbing or anything." And so she was like, "What do you mean?" And then the receptionist said, "He doesn't do it. It's his policy." And so the lady was recording the video, and she said, when I had it's a man, first I knew this is misogyny, because I'm the one telling you there is pain.
Yes.
You don't know because
You
have
idea.
you not?
Yes.
Have you had the IUD
Put
placed
in
inside you?
Exactly.
No.
So
And
how do you
so
know?
a lot needs to change.
A lot
right?
needs to change because even in training at my time, and I'll keep referencing me because I think it's pretty recent. It's been 10, 11 years now, but it's recent compared to my seniors, the people who taught me, which was much, much longer ago. But even at that time, there was the belief that the cervix didn't have nerve endings that give perception of pain. So that's why procedures were done without numbing agents or pain medication, because the belief is the cervix doesn't sense, and it's true. The perception of touch, pressure is different with internal organs versus how your brain maps out on skin or on things it has visibility towards. Internally, it explains why when you get a really bad period, you throw up or you feel dizzy. Because your brain is like, there's a problem.
There's something.
I just don't know where.
Yeah.
I can't pinpoint that it's the uterus.
Yeah.
Sometimes women will say, no, my period pain is back pain.
Yeah.
That's why that happens, because your brain doesn't have the ability to map internal organs as specifically as it does external. So then, if my training taught me that the cervix doesn't have perception of pain, of course I'm just going to do procedures assuming.
You're feeling nothing.
Yeah. And truly we were doing procedures with patients awake where I'd be like, the response by the patient seems to be different from what you guys taught me in the textbook. She's in pain. Yeah. That is pain.
Something is happening.
We need to do something about it. So even now, we don't have, and that's the thing about medical practice, takes a bit longer, just like with most other fields, for the protocols to be adjusted or for the guidelines to be adjusted to catch up with what's been, the evidence is saying now. And so I usually urge colleagues, just develop a protocol for yourself within your practice. Because if you're waiting for a standard national protocol or something from the government or something from international bodies, it'll take a few more years to catch up. But you know your patient is in pain. So have a protocol in place. In fact, even surely in surgery, when I go for surgery, you say yes, agree to general anesthesia. I'm pretty sure we can develop, in my clinic we do, we offer pain. In fact, I don't, you want without, I'm not your provider. I am not the one for you. So we have a consenting process to say, this is the options we have. We can give you pain management, we can give you light sedation, we can give you a block, a cervical block. So what option do you feel most comfortable with? And then we'll go right ahead. Because for some, it's trauma related. So I'm seeing you after you've already felt pain from a pap smear or from a previous procedure, so you don't even want to be awake for the procedure. Others, it's okay, I don't mind, I just don't want to feel anything. So it's literally, as you learn, do better and adjust and provide better services. It's that simple. This thing of believing women were built for pain,
then also, it's enough, men.
Truly, everything from puberty all the way through
and
to menopause.
Monthly, it's enough. But Dr. Claire, thank you so, you given such clarity to things that even for me I thought would be too difficult for me to grasp, and I've just understood things on a whole other level. So as we wind up, what's your mannerless message to the woman watching this?
To the woman watching.
And you can speak to her.
Right. To the woman watching this episode, my message to you would be to believe yourself, trust your gut, trust your body. If you're in pain, don't let me gaslight you, and I'm talking me as the provider. Don't let me gaslight you into believing that you're not, that it's made up or it's something you're imagining, or your pain tolerance is not the same as everyone else. I need for women to start to learn how to advocate for ourselves. The biggest way to do this, and this is not in a vacuum, you must be informed, you must be educated in order to advocate for yourself. Because again, in the space of, we're seeing a lot of it now with anti-vaxxers, for example. If you don't have the right information or you're misinformed, you cause more harm. So it's not combative. I'm not asking you to come in and fight with your doctor, but come in with some evidence, come in with research. I love my patients to come with a file. Let's discuss. Google, ChatGPT told me. I want that kind of a discussion. I feel like we should be more empowered to advocate for ourselves, and this comes from learning. You're free to choose your provider. That's another thing that I'll say. You're free to choose your provider, even if your insurance tells you otherwise. Legally, you have the rights to who your provider should be, so that then you can find the right person that you can have a conversation with. If I'm shutting you down, then maybe I'm not the right person for you. So learning to speak up we've been brought up in a society that shames us for everything, yet our bodies fight us from day one. So maybe a bit more grace to yourself, a bit more trust in how you feel and what your fears are. Understand that there must be a rooting, and trust and follow through so that you get the best possible care for you. And I'm talking because as a health provider, it's my biggest area of like pushback all the time, where I'll see women come in and say, what do you think? I've come because I want you to tell me. If I ask you, okay, you're here, you have a lesion, you have pain, whatever, what does it look like? Well, that's why I'm here.
Yeah, you
why
tell
would
me.
I look?
Yeah.
I'm like, no, I need you to.
Yeah.
This is your body.
And
This
you're
is
the
your vessel.
expert on your body.
Yes.
You spend more time with it than anybody else.
So let's kill shame. I think that's my biggest message.
Yeah. That is so powerful. And thank you so much for, first of all, taking the time to break down all of these conditions and illnesses and even just the processes that our bodies are going through in a way that we can understand it, right?
Yeah.
And also for the work you do and just making sure, you're talking about make sure you research, make sure you have information. You're going beyond the clinic, to the studio.
Exactly. I'm putting myself out there, guys.
Yes, with your show. Maybe you can tell us a bit about your show as we wrap.
So I'm a host of a podcast, Circling the Rabbit Hole. And why I called it Circling the Rabbit Hole, just from the English terminology of doing a deep dive is known as going down the rabbit hole. I'm trying to get you to the edge so that you can deep dive. Let's just circle. Let me make it comfortable for us to even just investigate. So that was the premise behind the name.
Yeah.
So it's Circling the Rabbit Hole. Primary focus is reproductive, sexual health, and related mental health, because we can't untie mental health from the way we feel about our bodies.
Yeah.
And for those who want more details, I go into very episode specific about various medical conditions to do with reproductive health, sexual health, and related mental health. And there's also conversations to the doctors as well. So it's not just for the patients, it's also to help providers. Sometimes I know we are busy, it's hectic, especially if you're in hospital practice as opposed to private practice. You may not be able to keep up, but that's why we're here. We are going to give you, digest the information, like you said, just digest it, make it easy to understand. And then I've had lots of people who use the episodes to have a conversation with your child about their body, use it to have with your mom about her body, just start to open the pathway to have these conversations so that, like we've said, we should be normalizing treating women with respect, with dignity, appreciating and understanding that her truth can be different from mine and it's also still a truth. So that's what the podcast is focused on. We're on YouTube, on Spotify, Apple FreePods, every podcast platform you can possibly think of. And it's just an easy, because most people will think medical podcast, will I understand anything? Literally today, that's what happens. Literally
just breaking it down
as much as possible, having specialists from different fields, especially so with conditions, like I've said, that need multidisciplinary approach, where we come and break it down from our different points of view with the different lens of the specialty that they're in. And those are the conversations we're having.
Man, kudos. Kudos. Many doctors, I had to twist my doctor, Dr. Sally, to come onto
it's not
season 1. I was just like, just go. And she's like, oh my God, not the cameras.
Exactly.
So kudos to you for doing that.
Thank
it's
you.
incredible work. And I've just enjoyed having you on this
Thank you so
show.
much. I'm glad we finally made this happen.
Yes, so much. I've learned so much, right?
Yeah.
And of course, all that Dr. Claire has talked about in terms of her show, we're going to link it in the description, as well as links to her Instagram so that you can keep updated with what she's doing and the information that she shares on there that can be helpful for you understanding more about your body. But what an incredible way to wrap season 4. And before I do, I just have to send a big thank you to 2 people. The first is Polished Homes, who have helped us create this wonderful set time and time again. They believe in the dream of being mannerless. And if you want to, make up your home or your bedroom or your guest room or gift someone something, be it a lamp, be it you need a new shade for your light, or you need a new table, new chairs, new headboard. They have incredible pieces that they source from all over Africa. So not just Kenya, Malawi, Ghana, Zimbabwe, it's incredible. We're also going to link them in the description. The second thank you has got to be to Her Way Studios. We started this season off with Terry, who is the founder. And yeah, it's a comfortable new home for us, and we appreciate them. So we've linked them all in the description. As for you, make sure you subscribe so that you do not miss out on the next season of For Mannerless Women, and share this episode with all the mannerless and nearly mannerless women in your life. Until next season, goodbye, and thank you for being part of the family.